All right. So, thank you for the kind introduction. It is my great honor to be standing here on the first session of the first day of the first conference of our TTCI. Because today we are holding a conference about immunotherapy, I would like to spend the first 30 minutes, telling you about history of how we got here. Okay, let's begin. The first evidence or the first record of cellular immunotherapy was recorded in the late 1800s, where Dr. William Coley, who is an orthopedic surgeon at New York Hospital, which is in present-day Weill Cornell Medical Center, he was saddened by the loss of his patient to sarcoma, and he was not satisfied with the state-of-the-art or the current practice back in the day, so he was determined to find a new way to treat sarcoma. Off he went to the library and the medical records, and he found anecdotal records of patients with sarcoma wherein the tumors regressed spontaneously after the patient got infected with erysipelas. So he determined that how about he would introduce erysipelas to his patient. And in 1891, he did exactly that. He introduced erysipelas using Streptococcus pyogenes intratumorally in a patient with incurable sarcoma. This patient is an Italian immigrant called Signor Sola. He came with a huge sarcoma in his cheekbone, and after a few injections of strep pyogenes into his tumor, the patient developed erysipelas, and the tumor gradually subsided. The patient would live on for another 8 years before the tumor recurred, and he passed away because of the recurrence. He would go on to try this treatment for a few more patients until he realized that injecting live bacteria into the patient is not the best strategy, because some of his patients, a lot of them, would die from sepsis. So he later modified his treatment to be, instead of live bacteria, to be two killed bacteria consisting of killed strep pyogenes and killed Serratia macescens. This would later be called Coley's toxins. But however, Coley's toxin were never proven effective in a more rigorous testing methodology of modern medicine. And it fell out of favor after the invention of radiotherapy. For the next decade, I'm not going to let you read that, but in a few moments, for the next decade, there were anecdotal evidence suggesting that people who got infected with tuberculosis tend to not get as many cancers. And then following the invention of BCG vaccine in the 1920s, Dr. Lloyd Old and Donald Clark at Sloan Kettering Institute, also in New York, published this paper titled Effect of Bacillus calmette-guerin infection on transplanted tumor in the mouse. They found that for a solid tumor in the mouse, if they infect the mice with tumors alone, about 80 to 90% of mice would die. The same goes for if BCG was infected to the mice 1 day prior to the inoculation of tumor. However, if they stretch the timing between infection with BCG and the inoculation of tumor to 7 days and onwards, then they found that infection with BCG actually protected the mice from getting killed by the tumors, and the reduction is quite drastic. They also try to prove their point. They also try with what is called Ehrlich tumor, which is an undifferentiated peritoascitis cancer in the mice, they found that with control mice that were not infected with BCG, the mice would die sooner than the one that were infected with BCG 12 to 14 days earlier. Unlike Coley's toxin, this strategy went on to be proven effective in bladder cancer, and this infusion of BCG solution remained the standard of care for patients with non-muscle invasive bladder cancer up until this day. So in the late 1800s to the 1970s, we knew that non-specific inflammation can cure some cancers. Next, I would like to jump across to hematopoietic stem cell transplant, a method that was pioneered by Dr. Edward Thomas, who himself would go on to be awarded the Nobel laureate in physiology and medicine in 1990. However, in the early days, the goal of HSCT was not to use the transplanted cells to reject the tumor. The idea back in the early 1950s was to use full body radiation, because back in the days, chemotherapy was not as developed. So they used full body radiation in hope of getting rid of all the stem cells in the patient. And the transplant goal, initially at least, was to just reconstitute the stem cells of the patient. But then, in 1976, Dr. Alexander Pfeiffer, this guy here, also a colleague of Dr. Edwards, in the middle, he, and I quote, he reported that the tumor in this case is a friend leukemia, a leukemia in mice. The tumor is immunogenic and sensitive to an immunologic response directed against its antigens. When inoculated intraperitoneally, as few as 100 cells will kill adult mice. But when inoculated subcutaneously, as many as 10 million cells will not grow progressively in most mice, but will render them immune to lethal tumor intraperitoneally. Therefore, cells immune to FBL3 can be obtained by inoculating mice one or more times with a viable FBL3 subcutaneously. So following this method, he tried to cure mice with FBL3 inoculation by adoptively transferring cells from another group of mice that were immunized against FBL3. And sure enough, he showed that in the group with no treatment, almost all of the mice died in about 20 days. Then, if he give cyclophosphamide in combination with control cells, the mice also died a bit later. But if he give the mice with cyclophosphamide plus the immunized cells, then the mice continue to live. Notice the number of mice, about 100 per group, the number that would make any IACUC these days balk at the number. And this idea was soon taken to the clinic, again with Dr. Edward Thomas and Dr. Pfeiffer. They started to find that in patients who develop GVHD at a stronger degree, they tend to have more relapse-free period. So they remain in remission for longer, although the overall survival was not better because complications of GVHD offset any benefit of tumor remission. So they soon realized that GVHD and graft versus leukemia are basically two sides of the same coin. In 1989, they tried to intentionally promote GVHD in order to better suppress leukemia. Back in the days, this was known as Buffy coat infusion, and it is now known as donor lymphocyte infusion. So what they do in this procedure is that in patients who receive HSCT and then relapse, they would be given another dose, this time not the whole stem cells, but just the Buffy coat of the same donor. This did not prove to be effective in this study with a lot of mixed lymphoma and leukemias of different types. But even though in this particular study, which was the first one, it was not effective, this method would be tried by other groups and now is known to get some degree of effectiveness when used against CML. So now, from 1959 to 1989, we knew that allogenic lymphocytes can cure some cancers. Next, I would like to talk about interleukin-2. Interleukin-2, first known as T-cell growth factor, was identified in 1976. And its cDNA was first cloned in 1983 by Professor Taniguchi Tadatsugu. This discovery of IL-2 paved the way for this Professor Steven Rosenberg, who tried to administer IL-2 in hope of boosting more T cells in the patients. He first proved the idea in several papers from the 82 to 85 in mice, and then he took the idea to patients in 1985. But not only did he administer IL-2 systemically, he also gave the patients T cells that were ex vivo grown in IL-2. So systemic IL-2 plus peripheral blood lymphocytes that were grown in IL-2. In this paper, he treated, in 1985, he treated 25 patients with metastatic tumors. He got 10 partial regression and 1 complete remission. That 1 complete remission was found in metastatic melanoma, which would be an important thing for immunotherapy because melanoma is a special kind of cancer that responds really well to immunotherapy. So you know what, you can guess where this is going from. Because Dr. Steven Rosenberg, he was trained as a surgeon, and he had an idea, if I can use peripheral blood lymphocytes, why not use the lymphocytes that are already in the tumors? Because his hypothesis was that the lymphocytes that are already in the tumor should be tumor reactive. So he tried that with his paper in 1988. Instead of using PBMCs, he used what we now call TILs, or tumor infiltrating lymphocytes. He found objective regression in 9 out of 15 patients with metastatic melanoma, which that number at the time was higher than IL-2 systemically alone, or IL-2 systemically plus IL-2 expanded lymphocytes. So now we know that ex vivo expanded T cells can cure some cancers. Now I would like to jump back to basic immunology a bit. We have the advantage of modern knowledge, which was not known back in the day, but with the advantage of modern knowledge, we know that when the receptor of T cells, or TCR, recognize its antigen, its cognate antigen, it specifically recognizes the combination of peptide plus MHC. If we were to replace the MSC while retaining the peptide, the same TCR would not recognize it. In the same fashion, if you replace the peptide without replacing the MSC, the same would happen. They would not recognize. This is quite cumbersome if you want to redirect T cells for some universal recognition. Drawing from this knowledge, and also the knowledge that both immunoglobulin, also known as B cell receptor, and T cell receptor, they both belong to immunoglobulin superfamily, meaning that structurally they are similar, which prompted this group from Fujita Gakuen Health University in 1987 to try and test a hypothesis that can we replace the CDR part or the variable parts of TCR with those that come from antibody. And in this paper, they found out that yes, it actually can be done. However, with this configuration, they need double transfection of the one chimeric chain here and another chimeric chain here. And they have to hope that both of the chimeric chain would pair together to give the desired results, and not pair with the original one, because back in the day they don't have CRISPR-Cas9 to knock out the natural TCR. But anyway, this strategy, it's a proof of concept, but it's not yet applicable for clinical application because you need double transfection. Then, a few years later, in 1991, a group from a medical institute in UCSF found out that of all the accessory proteins that come together to assemble TCR, meaning CD3 eta, CD3 delta, CD3 gamma, CD3 epsilon, and CD3 zeta, one would only need CD3 zeta alone, and that alone would be sufficient to activate T cells. They connected CD3 zeta to CD8 because if they obliterate this transcellular part of CD3 zeta, it would not dimerize. So they specifically chose CD8, which would dimerize in its natural conformation, to maintain the dimerization for CD3 zeta. And they found that this homodimers would be able to activate T cells on its own, independent of TCR, TCR. So this, now we are moving away from the full TCR complex to be able to independently activate T cells independent of TCR. And then 2 years later, a group of Israeli immunologists, Selik Eshar and his team, found that if they link the VH, the heavy chain, variable heavy chain, with the variable light chain of antibody together using a synthetic peptide shown here in black noodly thing, this alone would be able to recognize the target antigen as well. But in their study, they used CD16, which was known back in the day to be able to activate NK cells. What they did not know is that CD16 worked by recruiting CD3 zeta to work. So if we combine everything of all of these three papers together, using just the CD3 zeta combined with SCFV, then we get what is now known as the first generation CAR. Following the invention of first generation CAR with SCFV and CD3 zeta, a few clinical trials, a few small clinical trials were initiated. In all of them, the engineered T cells lasted no more than 2 months, and in all of them, no regression of tumor was found. This quickly became they soon realized that T cells, they don't work with just one signal. They need 3 signals. And what is missing in this construct is the second signal. And in 1998, this paper came out. In my personal opinion, this is the game changer. It transformed CAR, which back in the days was known as T-bodies, from a nice proof of concept, nice engineering, to something that's actually applicable by fusing a co-stimulatory domain into the chain. They tried both SATA first, CD28 later, and also CD28 first and CD3 SATA later, after. And they found that this particular configuration, worked about 20 times better than the first generation without co-stimulatory molecule, 20 times better measured by IL-2 production. And this configuration with SATA first did not express efficiently. So this was the birth of the second generation CAR, which would go on to become the basis for most CARs in clinical trials today. The rest is history. Here, shown here on the left is Bill Ludwig, the first patient ever to receive CAR-T19, now known as Kymriah, in 2010. His indication was CLL, and he went into remission after failing multiple rounds of chemotherapy. But after receiving CAR-T19, he went into remission for 11 years before he passed away 2 years ago because of COVID-19 pneumonia, but that's not cancer. To the right, it must be noted that Bill is the lucky person because it would later be proven that only about 1/4 of patients with CLL would respond to CAR-T19. So were Bill not to respond, the fate of CAR-Ts would not be as good as today. To the right, we have Emily Whitehead, the first pediatric patient of CAR-T19. She received it for relapsed refractory ALL, and she's now just celebrated 11 years of remission. So, up until last decade, we knew that T cells with synthetic receptor can cure some cancers. Later on, there would be a lot of developments and further refinements to the design of CARs. The third generation incorporates one more co-stimulatory domain. The most common configuration would be for 1BB ligand and CD28, but other combinations have been tried as well. The fourth generation CAR would incorporate motifs that would induce the production of cytokines, and the next generation CAR or the fifth generation CAR would incorporate would have functions other than that. For instance, the activation of JAK-STAT pathway, which is the downstream signaling pathway, if the T cells were to get the third signal, which is signals from cytokines. It must be noted, though, that although the third to the fifth generation have been tested in vitro and in vivo, all of the approved therapies, all of the approved CAR therapies use this design, the second generation design. So up until today, you can see that CAR-T in clinical trials outnumber other methods of cellular immunotherapy by a number of one order of magnitude, about 1,000 trials worldwide. About 3/4 of them denoted by this light blue color, teal, green, and gray color. 3/4 of them are against liquid tumors, and about 1/4 of them here, they're jutting out piece of the pie here, are directed against solid tumors. So that's the landscape of CARS trials today. I would like to point out to this landmark trial called ALIENA trial, which is the trial of CAR-T19, also known as T-cell, also known as Kymriah. This is the phase 2 clinical trials with, how many patients are there? 79 patients. They found that in the group of patients just like Emily, R/RALL, at 3 years, at 4 years after infusion, about 60% of the patients would still survive. And then the final analysis came out in EHA 2022. They found that at 5 years, the overall survival rate is 55. Because this is a phase 2 trial, there's no comparator arm. So to put that into context, I present to you the clinical trial of a chemotherapy called clofarabine, intended to treat the same target of patients. And they found, please note here that the time is measured in weeks. In this group of patients, by about 2 years, only about 10% of patients still survive. It's not directly comparable because it's 2 different trials, but to give you some context of how well Kymriah works against ALL. So that was the present situation of CAR-Ts. Where are we heading from now on? In the future trajectories of CAR-Ts, in 2021, CD19 CAR was tested for other indications that is not cancer, and that is SLE, to wipe out all the nasty self-reactive antibody-producing B cells. Several groups are trying to test CAR-Ts in solid tumors, and the golden goose, everyone trying to produce CAR-T not from autologous source, but trying for allogenic source or iPSC-derived CAR-Ts, or alternatively, try to engineer CAR-T inside the patient body, or engineer it ex vivo, but infuse it just after the transduction and have it expand inside the body. There are also other groups proposing alternative designs like star receptor or hit receptor. And who knows, looking back at all the history that preceded us, the next paradigm may not even be CAR, but other type of cells or other types of design, some of which maybe you'll find today. So with that said, I will end my presentation here. Thank you.